Hello, friends. So this is the 57th COVID update on 24th December. So the talk I gave in one of the meeting was therapeutic options. What are the changes in second wave? And this is becomes more important in the light of possible third wave that the world is facing. I mean, more importantly, our India may face because we know the Omicron fourth wave in the Western world is significantly increasing. The cases in UK and France are really increasing. And in India, it is expected the cases may see a surge in January or February. So it is important for us to know what all drugs that we have used and where we are and what are the drugs that tends to hold promise for possible third wave. Having said that, we wish hope and pray third wave doesn't happen. So when you really look at the whole progression, I'm sure this slide most listeners would have seen multiple times. So these are the different stages of COVID. So the initial phase is the active viral replication, and the second phase is the inflammatory phase. And the whole, the game changer in COVID is to see and have interventions in this viral replicative phase so that patients don't progress into the inflammatory phase, because we really don't want patients going to inflammatory phase having oxygenation issues and needing hospitalization, because that would put enormous burden on the healthcare facility. And if we have good tools where we can really halt this viral replication and prevent progression, then we would really vanquish this disease. And there are multiple interventions that has been tried in this viral replication, but most have really not shown good mettle in controlling this. So what has been our journey with COVID in India and also in the world across? So in COVID, I'm sure every listener would know there are four pillars in the therapy. The first pillar would be antivirals, and you saw that the whole magic is to stop the replication, and if that can be done, then we know that disease wouldn't progress to inflammatory phase. And we know we started off with hydroxychloroquine, and many physicians vouched in using ivermectin, and then there was lopinavir and ritonavir, which are HIV drugs, protease inhibitors, and then came the favipiravir. Unfortunately, none of these showed good promise in controlling the disease. And then we had remdesivir, and now we have two new antivirals, which we'll be talking a little bit on, especially on the molnupiravir and nirmatrelvir, which is come with a trade name called Paxlovid, which has a nirmatrelvir along with small amount of ritonavir. So the first four are out of our armamentarium, and even remdesivir was slowly de-emphasized, especially after the solidarity trial. WHO, in fact, in its recommendation, does not put remdesivir as something one should be using, but we've had multiple debates, and we still believe that there may be promise until we were sort of getting non-enthusiastic about it. We just got a trial 2 days back about its role in stable patients, which we'll talk about. So the second important pillar of COVID management is anti-inflammatory therapy. So we had steroids, and I'm sure every listener would know that we've had debate between high dose versus low dose, but now the evidence is reasonably very clear that there is no benefit of using high dose steroids. So we can stick to 6 mg dexamethasone or its equivalent dose, which is 32 mg of methylprednisolone or prednisolone 40 mg. So that is something one could, because we had a COVID-2 trial and there was another trial which came even in ARDS in JAMA. We did not show difference between high or low steroids. And then we had this budesonide inhaler in the initial phase to prevent progression. So there was a STOIC trial that came. But after that, there was no other study, and even the enthusiasm on this is slowly sort of dwindled, and we're not too excited about it anymore. And then we had this IL-6 receptor antagonist and the other MABs. So the tocilizumab is IL-6, so it is extensively studied molecule. So there's good number of studies, and this has held the promise and still holds mettle in patients who have worsening gas exchange. But other MABs like itolizumab and bevacizumab really did not show huge promise, and there were no good, well-conducted trials. And bevacizumab is a VEGF inhibitor, and so these really did not show huge promise. And then came the JAK inhibitors, baricitinib and tofacitinib. So good trials came in this in NEJM, and they still seem to hold promise in patients who have worsening gas exchange. So these are the armamentarium that we have tried. Colchicine came on and off, so a little bit of enthusiasm again in the initial phase, but really was not convincing overall. So this is also out of our armamentarium. So the third pillar is anticoagulation. So, and we knew for sure in autopsy studies that COVID is a prothrombotic disease with a lot of microthrombi formation at the alveolar capillary level, which was hindering the gas exchange and BP mismatch. So then there was a whole debate about whether prophylaxis has to be used or therapeutic. In fact, we had debate on the national forums about therapeutic is the way. But then we had a very good studies again, which came in NEJM, comparing therapeutic low molecular weight heparin in severe COVID. And what they really found was in severe COVID, therapeutic anticoagulation really did not lead to favorable outcome. In fact, it led to worse outcomes. But having said that, there was another trial that came on the same time in NEJM where they showed therapeutic anticoagulation in mild to moderate COVID, in fact, showed better clinical outcomes. So it's very difficult for us to decipher this. So what we have agreed at this point of time generally is prophylactic is here to stay and prophylactic is safe. Therapeutic anticoagulation possibly could be reserved to very high risk individuals who already have evidence of venous thromboembolism or other risk factors, which puts them at a high risk in a select group of patients at the clinical discretion is what we could agree upon. Aspirin really did not convince us. There are anecdotal reports of thrombolysis. The other vasodilators, Riosigat and Avicipadil is an interesting molecule in ARDS. We'll talk about it. So again, no huge trials, but Avicipadil, there is one COVID AIV trial, which I'll talk about briefly. So the fourth pillar of COVID management was antibody cocktails. And this again raised our enthusiasm, and they possibly will hold promise as we move along. So Casirivimab and Imdevimab is what is available, and Bamlanivimab is another one which is still not available in India. Then there was this interferon lambda. There was a Canadian study which showed good promise with the usage of this pegylated interferon, and there was a pegylated interferon alpha. So we need more studies to convince ourselves about interferon. But antibody cocktails is something that is possibly here to stay. And what about the convalescent plasma? In fact, there is recommendation against the use of convalescent plasma, and there is really no benefit, although initially there was some enthusiasm. So these are the four pillars that we have tried, and we'll conclude as to what possibly will remain for the third wave. And the other dimension of COVID management is the oxygen therapy. Pretty much they all remain they remain in place and they have a value. So all oxygen devices, but what has emerged in this whole COVID is the usefulness of a simple, cost-effective tool where there is no cost involved is the awake proning. So awake proning in every patient who is on any oxygen device, including HFNO, NIV. So there was a debate that HFNO is superior to NIV, even that is debunked. So whatever device, if you have NIV, please use it. That is found to be very effective. And even when there are NIV, encourage patients to prone. I think that is the key essence. And even when they're intubated, mechanical ventilated, proning is something one has to consider as per the criteria and as per the clinical situation. So initially there was a debate about whether these COVID patients should not be intubated early, but even that was proven to be false. So the intubation criteria remains the same as any other ARDS. So if someone is not really doing well, so one could go ahead and intubate. In fact, there are certain indices like ROX indices, which can be used as a tool to determine which are the patients who possibly should be considered for intubation. Then there was this initial L and H type, where L is low elastance, high compliance, H is high elastance and low compliance. All this hasn't stood the test of time. So we just have to look at it as ARDS and treat them. And then in a refractory cases, ECMO has been tried in anecdotal in lot of case series and studies, and even hyperbaric oxygen therapy has been tried. So these are all like in a special circumstances as a refractory respiratory failure as a salvage measure. Then pirfenidone and nintedanib antifibrotic drugs, we do not have really great evidence for usage of these, and lung transplant as a desperate measure in someone who is not improving on ECMO. So this pretty much has been the treatment armamentarium over last 2 years in COVID. And in fact, we did publish this nice review article on the role of HBOT, the role of HBOT in COVID. So now let's look into, so once the remdesivir after the solidarity trial, the WHO not really excited about recommending this remdesivir. So this study just came. So when we were thinking of almost putting this on the backbench, so this study came just 2 days back, around 3 days back, early remdesivir to prevent progression to severe COVID in outpatients. So this study was done in patients who had symptom onset within 7 days. And they took the patient, the inclusion criteria was they took the patient with one of the risk factors which would indicate that patients would have disease progression, which is patients who are over 60 years, who are more vulnerable for disease progression, obese individuals who are at a higher risk of disease progression, or any patient who has any of the comorbidities like diabetes, hypertension, COPD, any of these comorbidities which would otherwise put them at a risk for progression were taken as a inclusion criteria. And the dose typically as a remdesivir 200 mg OD and 100 mg once a day for 3 days. So the primary endpoint they looked was medically attended visits to the hospital and 28-day death. So 61.6% of these patients were diabetes, 55.2% were obese, and 47.7% of these patients were hypertensive. So results, mean age was 50 years, 47.9% were females. So they had 562 patients, 279 in the remdesivir group, 283 in the placebo. As you see, the 28-day death was significantly less in the remdesivir group as compared to the placebo, statistically significant, and medically attended, which means the patients needing to go to hospital for possible worsening symptoms also was significantly less in remdesivir as compared to the placebo. And adverse events, there was no difference. So the conclusions the authors made was remdesivir for 3 days reduces the risk of going to hospital and death by 87%. So this is a very interesting study that came in the light of almost writing off this remdesivir in a standard, because all the previous studies like ACT study, if you recall, we had rationed this remdesivir predominantly for usage in patients who needed oxygen. And in fact, when they did a subgroup sort of analysis, they found the maximum benefit of remdesivir to be prevailing in patients who are on oxygen and higher up, and not in stable patients. So this was the earlier studies, but now we have flipped the table and telling that even in stable patients, it seems to have a good effect in reducing the progression of the disease and deaths. So this is something which really heightens our curiosity, and this again has to be considered whether one would contemplate on using this IV on an OPD basis, which has its own logistic issues. So now we'll move to this new drug and an interesting drug which has come, molnupiravir. So this again, any piravir, as listeners would know, act act through RNA-dependent RNA polymerase. So this is the chemical structure of molnupiravir. It's a potent ribonucleotide analog which inhibits the viral replication. So the key thing about molnupiravir is it has this N-hydroxycytidine triphosphate, or simply called MTP. And when molnupiravir is ingested, it is cleaved into this active component called EIDD in 1931. And by the action of kinase, it produces this active molecule called MTP. And RNA-dependent RNA polymerase, which looks like this, typically uses CTP or UTP, which is cytidine triphosphate or uridine triphosphate. But in the presence of MTP, it utilizes MTP and incorporates guanine and adenosine, and it causes anomaly in the viral sequencing. So which means it produces a defect in the RNA sequencing, which is called viral error catastrophe, which means it induces mutation, it induces anomaly. And by creating this anomaly or viral error catastrophe, so the further viral replication is halted. And this is how typically even remdesivir works, but through a different pathway, and even favipiravir works. So another concern of this causing this anomaly is its ability to induce a lot of mutations is a concern raised by the scientific body. So this is in essence the mechanism of action. So let's look into the study. So this was a very good phase 1 randomized controlled trial from the US and UK authors, which basically looked at the safety and pharmacokinetics of molnupiravir. This was a phase 1 randomized double-blinded placebo-controlled trial, 3:1 randomization. They took patients 19 to 60 years, majority were males. So they had 3 groups. First group received 50 to 1,600 milligram in ascending dose in 64 patients. Second group got 800 in ascending dose, and the third group got 200 mg. And this was mainly to look into its impact when it was given in the fed state or in the fasting state to see how the absorption happens. And this molnupiravir was given for 5.5 days, and follow-up of this patient was done for 14 days. When you look at pharmacokinetics at 1,600 milligram, which is the dose that is defined for molnupiravir, the peak concentration levels was 13.2 nanograms per ml, and the medium time to concentration was 0.25 to 0.75 hours, about 1 hour. And 0.2% of the active ingredient was present at this dosage. So the active only 0.2% of this active ingredient was present in the serum at 1,600 mg dose. So at more than 800 mg, the active component of molnupiravir gets detectable in the urine, and this possibly is the reason, or they could fix the dose at 1,600 mg, because any dose less than 800 mg possibly gets ineffective. And the half-life is 1 hour and elimination is 7.1 hours. And as you see, when the dosing is less than 400 mg, the active component of molnupiravir, which is EIDD, becomes non-calculable. And it was found that when molnupiravir is given at a 200 mg in a fed state, again the active ingredient does not would not be calculable, which means the drug has a better absorption in the fasting state as compared to the fed state, but the authors say that it did not have any clinical relevance. So this is about the pharmacokinetics. So this was the phase 2 study of the molnupiravir. So they used molnupiravir 800 mg and compared to the placebo, and they looked at the day 3 viral presence. It was significantly reduced to 1.9% as compared to 16.5% in the placebo, and at day 5 there was no virus identifiable in molnupiravir. Again, goes on to show molnupiravir had a good effect in clearing the virus. And this is a graphical representation of different dosages. And if you see day 1, this is day 3. So this is a placebo group, 200 mg group, and 400. As you see at 800 mg, it was most effective. 1.9 was a 16.7%. And at day 5, the virus was not detectable in the molnupiravir group. So this is what was helpful in ascertaining and determining the dosage. So then this particular report came, which is an interim report, which was discussed in BMJ of the MODE study. So again, molnupiravir and placebo, 385 in molnupiravir and 377 placebo. They looked at the hospitalization and the death, and it was 7.3% compared to 14.1% in placebo group. Adverse events, no difference. And prior to this, there were 3 animal studies which was done in ferrets, in rats, in these by US and the Canadian group, and they had shown good effect of molnupiravir in clearing the virus. So the interim reports of MODE study, which was conducted by the Merck, came out on 26th November, and this was published in 13th, I think 17th December in NEJM. So they recruited 1,433 patients, 709 in the molnupiravir group and 699 in the placebo group. And the hospitalization and death, as you see, was 6.8% in molnupiravir and 9.72 in the placebo, and that was statistically significant. And the deaths also was 1 in molnupiravir and 9 in the placebo. So again, goes to show that molnupiravir was effective in preventing the patients having worsening symptoms, needing hospitalization and the death. So a very positive study, and there was no serious adverse events. The predominant adverse events they found was GI symptoms, diarrhea in 7.1 and headache in 12.5% and some skin rashes. So that's about molnupiravir. So what we can reconcile is the phase 1 randomized control trial is a very good comprehensive study, which has really looked into the whole pharmacokinetics and pharmacodynamics to determine the dosage. And the phase 2 study also was a promising study in its ability to clear the viruses, and this MODE study. So I will discuss about the details of MODE study, the full details of the study in the next video. But as you see, the overall endpoint of reducing the death and hospitalization was significantly better in molnupiravir group. So then we'll quickly talk about antibody cocktails, which has held the promise. So this was a study which came in Jan 2021, looking at the Regeneron COVID-2, which consists of casirivimab and imdevimab antibodies. And these antibodies typically bind to the spike protein, because we know that COVID virus gains entry into the host cells through the spike protein. So these antibodies block the spike protein and prevents the entry of these virus into the cells. And these antibodies are known to bind to receptor binding domain. And there are 3 receptor binding domain on the spike protein. So this is a spike protein and they have 3 RBDs. So these antibodies bind to these 3 RBDs, and it is found to be even effective against mutant strains and prevent the entry of these coronavirus into the host cells. So these are the 3 RBDs. So this was a study which compared 2 doses of antibody cocktail, 2.4 grams Regeneron COVID-2 and 8 grams Regeneron with the placebo, and looking at the endogenous immune response to the virus. So the primary endpoint was to look at the change in the viral load from day 1 to day 7 and the percentage of patients needing hospitalization at day 29. So inclusion criteria was age more than 18 years and COVID positive, symptom onset less than 7 days. But the interesting part of the study was they measured the antibodies prior to randomizing into the study. So they looked at IgA antibody, IgG antibody, and the nucleocapsid antibodies. And this is a very interesting study. So 93 in placebo, 92 in each of 2 grams and 8 grams. So what they did was, in patients who did not mount antibody response, they found that the viral copies were very high, which means if patient has an inability to mount an effective antibody response, they had a higher viral load, as opposed to patients who had a good antibody response and where antibodies IgG and nucleocapsid and IgM were identified, they had a lesser viral copies. And they did a subgroup analysis to see in which of these antibody cocktail was more effective. And what they found was this antibody cocktail had more effectiveness or higher treatment effect in patients who had a higher viral load or who were antibody negative. So that's what was found. So they had 277 patients, 93 in placebo, 184 in the antibody cocktail. And as you see, the viral loads were significantly reduced in antibody cocktail group, and percentage of patients needing hospitalization was significantly reduced. And even its ability was much more profound in patients who were antibody negative at the baseline, and hypersensitivity was similar. And here they compared 2 doses, 2.4 grams and 8 grams, and they found interestingly there was no difference between the high dose and low dose in its ability to reduce the viral load, which means to say that's why you have this antibody cocktail which is split into 2 and administered to 2 patients, because even the lower dose was found to be as effective as the higher dose. And if you see pictorially, it shows so this is a patients with where antibodies were negative, and the treatment effect was more profound in patients where antibodies were negative, which means they had higher viral copies, as compared to the patients who had antibody positive, where they would have lower viral copies. So as you see, in patients who had 10 to the power of 4 copies, the treatment effect was little less as compared to the treatment effect, which was more profound in patients who had more than 10 to the power of 6 copies. So higher the viral load, antibody cocktail performed better in reducing the viral load and better clinical outcomes. So that was the conclusion made. So the conclusion they made was, so this antibody cocktail reduces the viral load, especially in patients who do not have endogenous immune response, who have no ability to produce antibodies. It had a better effect. And it had a better effect in patients who had a higher viral load. So this was the striking findings of this antibody cocktail. But now we do not know for sure whether this antibody cocktail will be effective against Omicron, because Omicron virus has an ability to evade the antibodies. So we need more data to see whether these cocktails perform as good as it used to in Delta virus and other viruses, other strains. Because Omicron has this antibody evading effect, and it has 35 mutations in the spike protein, and we do not know for sure if these cocktail antibodies can bind to these RBDs in Omicron. So that needs to be seen. And safety profile was very good. So now coming to last 2-3 minutes, so we'll talk about this very interesting drug, more of relevance to intensivists of Aviptadil, which is used in ARDS in sick patients who have already come to ICU. So Aviptadil is a vasoactive intestinal polypeptide called as RLF100. So it acts predominantly in the alveolar type 2 cells, which constitute around 5% of the cells in the lung. And it acts on the VPAC1 receptors and the ACE receptors. And 70% of the VPAC1 receptors are present on the alveolar type 2 cells. By acting on this, it facilitates good oxygen transport, it increases the surfactant production, and it maintains the integrity of the alveolar type 1 cells. And by acting on this, it prevents the NMDA-mediated activation of caspase and protects from pulmonary edema and inhibits the production of IL-6 tumor necrosis factor alpha and increases the surfactant production. So this is in brief the mechanism of action. And it also helps by this mechanism, it helps in restoring the barrier function between the alveolar capillary interface. And this is not a very new drug. So this has been tested over last 20 years in sarcoidosis, pulmonary fibrosis, and ARDS. And there are case series in ARDS in 8 ventilated patients where it showed some promise. That 7 were extubated and 6 were discharged. So now there are trials that are being conducted with Aviptadil. So the dosage is 50 to 150 picomoles per kg per hour for 12 hours. So these are the 3 trials. COVID AIV trial, which is of interest for intensivists. There is a Samicare trial, and there is Avikovit II, which is an inhaled Aviptadil for the treatment of ARDS. So there is the interim report of COVID AIV trial was released on 29th March 2021, but I couldn't get access to the full manuscript of this, and I'm not sure whether this has been already published because I could only get the interim data in our search. So this COVID AIV trial was done in 10 hospitals. The primary endpoint was to look at recovery from respiratory failure, discharge from hospital or hospital survival at day 28 and day 60. Secondary endpoint was to look at duration of mechanical ventilation and duration of extubation. So as you see here, they have taken sick patients who are already on HFNO, 127 patients randomized between Aviptadil and placebo, and they saw that the day 28 recovery was significantly better in Aviptadil as compared to placebo, statistically significant, and day 60 recovery also was significantly better in Aviptadil as compared to the placebo. So we really deliberated on 3 newer molecules: molnupiravir, resurgence of remdesivir, which has reinvigorated our enthusiasm into it, and antibody cocktail and Aviptadil. So what remains now for the third wave? So these antivirals still possibly holds promise. Remdesivir is here to stay. Molnupiravir, it sounds exciting, very provocative at this point of time. So I will so we need to see whether this really changes our ability to really preventing progression of the disease and mitigating our hospital admission. And it is FDA has very recently approved this Paxlovid, which is nirmatrelvir with ritonavir. So we need to see the full data of this study because there is a claim which was making WhatsApp rounds just 2-3 days back about nirmatrelvir's ability to reduce the hospital admission by 89% in the study they have done from the Pfizer group. So with anti-inflammatory steroids, so we have to stick to low dose steroids, 6 mg dexa or its equivalent dose of methylprednisolone, which is 32 mg. Tocilizumab, IL-6 receptor antagonist, is here to stay in patients who have worsening respiratory failure, and JAK inhibitors, baricitinib and tofacitinib, are here to stay. And with anticoagulation, we should stick to prophylactic anticoagulation, therapeutic anticoagulation only in specific cohort of patients who already have venous thromboembolism or arterial thromboembolism or who are at a high risk of developing thromboembolism is a specific cohort which a clinician could determine its usage. Otherwise, most COVID patients prophylaxis is good enough. And antibody cocktails, we need to see whether this holds promise even in Omicron. So we aren't sure at this point of time, but they are here to stay. And bamlanivimab and etesevimab is still not available, and they may soon be available in India. There is another maps called sotirimumab, which also may make its presence here. So So thank you very much. And this was the WhatsApp messages I'm sure you would have seen, Paxlovid, which is claimed to reduce hospital admission by 89%. So I would end my talk with this beautiful quote: everything you have ever wanted is on the other side of fear. So thank you all.